adjust the mic. Yes, I'll be the pinch hitter for the original closer, Greg Allen. And you've heard the term DSRip, and Foster, Dr. Zucker, our leadership panel also talked about DSRip. But beyond that, I'm just really curious, for the providers in the room, how many of you have actually been involved in the whole DSRip project design, discussions about implementation? That's great. This is good. This is good. Because I think sometimes, my biggest fear actually is that this is not the traditional grant program. It is not at all a grant program. This is about an opportunity to really transform the system in a way that I don't think many of us who have been around for a long time, this opportunity hasn't come around, and this is really our time to do that. And I think from the discussions that we've had today, really it is a sea change opportunity for us. And for those of you who are residents or have recently graduated, this is the world that I think that we're all just trying to build and move towards. Just some historical context, because when I saw this, I don't think I've actually realized it while living through it. Just wanted to share this with you. This is from a New York State Health Foundation report that was published in February 2014 that was looking at data in sort of the mid to late 2000s. New York has fared poorly on several measures of avoidable hospital use and costs. And I think, the blue banner there of New York State ranked 50th for potentially avoidable hospital use and cost of care. I don't like being last anytime, especially in something like this, and I'm sure you feel the same way. So again, just some of those indicators, the numbers to the right are the state rank, how New York State ranked in the country around those. And again, this was the source here was the Commonwealth Fund study that was looking at data from that sort of early 2000 to 2007, 2008 range. So given this, we have to do something, right? And I think one of the things that, with the Cuomo administration coming into being and looking at, where we were in terms of Medicaid expenditures in New York State, which have typically been over $50 billion a year, a number 3, state budget cost line that you and I as taxpayers pay for, and then you just saw what the kinds of quality indicators that we have. Fairly poor performance for the amount of money that we're spending. So the Medicaid redesign team was convened, many work groups, some of you may have been involved in that, and to see how we could reshape the whole Medicaid system to reduce avoidable costs and improve quality. And in that negotiation, really was, as these reforms started to take place and savings were anticipated, there was a Medicaid redesign team waiver that was negotiated with CMS. It took about a year of negotiations, but the idea, and let me just sort of fast forward to these slides, was to show that, with the MRT reforms, the trajectory of total Medicaid spending started to go down. And so you can see that instead of going on that, if there are no interventions that happen, it would keep going up. But you could start seeing that as of 2011, things started to level and to start going down. That's overall spending. Even more dramatic is this, is that the actual Medicaid spending per recipient, you could see dramatically went down. And I think what's even more interesting about this is that, that's per recipient, but back here is actually with the ACA and expanded Medicaid coverage, about 1 million more people got added to the Medicaid rolls. And yet this is where we are in terms of overall spending. So out of those savings, really, the negotiation with the federal government was there's $17 billion that we're saving for you in terms of the federal match, because the way Medicaid is, it's 50% state, 50% feds. So out of that $17 billion, we would like to recoup some of that to reinvest in our system, because whatever we're doing, it's not financially sustainable. We need to go through a radical change and how we provide care, how we pay for care, and change the way we're paying for care in order to get the change towards quality care, and not be on the fee-for-service treadmill, which just rewards people financially for volume. So as Foster was saying, so $6.42 billion is devoted to the DSRip program, and so we'll get into what is the DSRip program. And I realize, you know, I get the sense that some of you, a lot of you have been involved in the projects, but I hear that some people haven't been. I'll try to get through this quickly in terms of covering the sort of basic DSRip principles. One of the key things, again, is, you know, a lot of the work that you guys have been doing around patient-centered medical home, and that whole patient-centered, you know, experience in the healthcare system. One of the key, and to use those as building blocks for the system transformation. Transparency for us as in the policy arena, really to be as transparent as possible, engage stakeholders, if you've looked at the DSRip website, everything we've ever said, ever recorded, ever provided in terms of slides is up there, okay? Including webcasts of the DSRip oversight panel proceedings that lasted over 4 days. Collaboration, I think if you've heard Jason Helgerson speak, DSRip is all about collaboration. And then as we talked about accountability, it is that every PPS is committed to meeting the project metrics that will be driving the transformation and driving performance, and with that is then the payment that's based on that value that's measured through that performance that each PPS has committed in their application. And again, you know, that is the better care and less cost. So key components, as was mentioned, 25% as far as reductions over avoidable hospitalizations over the 5 years. Let me just skip to this. Performing provider systems, healthcare is local. I think it's, you know, what's been great about seeing this process unfold is that competitors in the same area have actually started to talk to each other and perhaps have even come together in PPSs. We started with 42 PPSs. We now have 25 because a lot of those have come together and looking at how do we regionally begin to engage and move these projects. The projects are the ones that define, really have value points associated and drive the payments. So the highest value ones are the ones that really are speaking to integrated delivery systems. And, you know, this was not a situation where people could choose projects. These projects were designed in a way, and in fact, again, negotiated quite a bit with CMS, as these are the projects that would really help transform the system. It is, in terms of the foundations to be able to carry out those projects, and that would provide the sustainable foundations for going forward. Attribution really had to do with, again, looking at running our Medicaid claims data, looking at where people, what providers they went to, and making those decisions, and the application quality itself as far as how was the PPS proposing to carry through these projects, who are their partners, and what type of speed and scale were they committing to. And again, the performance-based payments are all detailed out in some of the attachments, CMS attachments I and J, that you can refer to. I think another key piece for DSRip is, and for you all, is regulatory relief. We know that a lot of behavior has been, or you know, programmatic silos have been promoted, you know, because of the kinds of regulations that have been in place, and this was the opportunity to say, okay, identify for us what are the regulations that stand in your way to carry out these projects. And these have been really reviewed across the agencies. As much as there's been collaboration amongst you all, there's been collaboration amongst the different state agencies in looking at these regulations and how we can really pave the way for that implementation. And particularly around the integrated behavioral health piece, I think for those of you who applied, you will see some of the regulatory relief, you know, provided there. And then the additional thing of $1.2 billion of additional capital, $1.2 billion of capital funding that's been made available, again, preference given to those that are directly related to DSRip projects. So again, all of this is meant for lasting change. It's not about what happens at the end of 5 years. By the time you've built all this, and by the time we get through value-based payment, this should definitely have changed the system and how we can all move forward. Okay. I think those of you involved, here's the kind of list of, here's the collaboration network, the performing provider systems. It's hospitals, health homes, SNFs, and, primary care clinics and FQHCs, behavioral health providers, home care agents, and other key stakeholders. And I would stress the other key stakeholders. Again, we deal so much with the issues around social determinants of health that really impair our ability to, or impair the ability of our patients to successfully comply with that care plan that we've put out there saying, why can't they do this? And I think, again, if you've got that housing provider in the community, or you've got that other, navigator resource in the community, these are the folks who can, help make such a huge difference as far as preventing readmissions and all the rest. This is a very busy chart, but this is, again, to kind of show you where primary care is stressed in the whole DSRip projects process and along the continuum of care. All those highlighted in red particularly. And then these are just samples of those projects, which it seems like most of you are aware of. Just again to focus in on 2A2 right there, that second line, that's where it speaks to the PCMH certification in advanced primary care. So clearly, DSRip is all about trying to put that focus on primary care to build up primary care, build up that primary care capacity, and create that as part of the whole integrated service delivery system. And then, the Domain 3 projects you have here really have to do with, these will be measured through HEDIS scores. And then here is the New York State prevention agenda that's been now adopted through Domain 4. So all these, wind up being payments, incentive payments to the PPSs, again, based on metrics that will be measured either and reporting. So let me, and here's again sort of the gradual progress towards the premium APC that again is being supported through DSRip. And as we've mentioned, as Foster has mentioned about how we get there, there's the NCQA type of checklist piece, but then here's sort